So welcome to Decoding CTO, case 29. I'm Dr. A. Sharath, interventional cardiologist from Medicover Hospitals, Hyderabad. Today I'm bringing up a good case of pseudoaneurysm, coronary pseudoaneurysm, which was closed by retrograde plaque or flap shift. So this case is a 64-year-old male, status post CABG, more than 12 years old, with patent Lima to LAD and patent SVG2AM, but SVG2RCA was occluded. And it was intervened twice. Patient underwent stent for SVG2RCA. Despite that, patient came back again with exertional angina with inducible ischemia in RCA territory, and CAG showed instant stenosis of SVG2RCA. There are two stents inside SVG2RCA. As the operator couldn't do RCA CTO intervention, so they again did a balloon angioplasty to instant stenosis, and patient was posted for CTO intervention later on. This case was done in Jabalpur, case of Dr. Amjad Ali, while I proctored there. So this is dual angiography. You can see SVG2RCA and AL guide in right coronary artery. So it's a very short segment, total occlusion of right coronary artery. You can see it's a very short segment, and you can also see a pseudoaneurysm here, which was not there before. This aneurysm was formed due to repeated antegrade attempts which were done in previous sittings, and as this space was connected to aorta, it got expanded and formed a pseudoaneurysm. And this is a site of stent in stent where it got occluded again, and POBA was done just to tide over the crisis. And now coming to wiring strategy in this case, being a short CTO sitting in proximal RCA and with a patent venous graft to mid RCA, so it's not a challenging case to do a CTO wiring. But what matters here is the pseudoaneurysm. So when you are planning wiring strategy to exclude pseudoaneurysm, your options will be limited. So that's a major challenge here. So the pseudoaneurysm at the proximal cap is a major challenge, so which in fact reduces your antegrade wire navigatability, and also short proximal coronary before CTO, so which makes your reverse cart more and more difficult, and also externalization quite difficult. So if we look at different wiring strategies to exclude this pseudoaneurysm sitting close to the proximal cap, this is a CTO and this is a side branch. So what we can do is we can take your antegrade wire into subintimal place here, juxtaposing aneurysm, and then re-enter into true lumen and shift this entire flap as well as plaque onto aneurysm to close it. So this is one option. And another option is you can come retrograde directly and send your wire opposite to the aneurysm wall, and then you try and shift this plaque or flap onto the aneurysm. So this is another option. And the next option is kind of retrograde subintimal entry into the juxtaposed wall of aneurysm, and then re-entering proximal to the aneurysm location and externalizing and shifting this whole thing onto aneurysm. So these are the three wiring strategies which might work in excluding this aneurysm. from coronary lumen. So what we did in this case is, so we directly went ahead with retrograde. Since antegrade wire maneuverability was very poor because of the pseudoaneurysm. So this is a retrograde caravel through the SVG into proximal RCA, and then we advanced till the cap. So you can see we advanced microcatheter till the distal cap. It's a very short CTO, and the challenge was only the presence of aneurysm. We can also see the anchor balloon, so which is supporting guide to sit in ostial RCA. And at the first attempt, my retrograde wire escalated to Gaia 2, just went into aneurysm. You can see here both antegrade and retrograde wires are into the aneurysm. Yeah, so after initial attempt of Gaia 2 went into aneurysm, we further escalated retrograde wire to Gaia 3, which was redirected into the wall away from the aneurysm. So you can see here, so as shown here, and then we did an extended reverse cut in the proximal RCA, and so the retrograde wire is directed into true lumen proximal to the edge of pseudoaneurysm. So now you can see, retrograde wire is into the proximal RCA or ostial RCA, and then into the aorta here. You can see this is retrograde Gaia 3 into the aorta, and you can also see here, so where the wire is in relation to the aneurysm. So the wire is traversing from the inferior wall of aneurysm, and it's not within the aneurysm. Yeah, so to confirm wire position and its relation to aneurysm, so we did an IVUS. So I'll show you what exactly IVUS shows here. So you can see here, so this is the aneurysm, and this is the sinoatrial branch from which I'm doing intravascular ultrasound, and this is the retrograde wire, that is Gaia 3. So how the wire should look is, the wire should be outside aneurysm. It shouldn't sit within the aneurysm, so it should be in the outside wall of aneurysm. So in this case, this is the inferior side of right coronary artery, and this is the superior side, where the sinoatrial branch is coming, is superior side. And when you come proximally, so you can see here, so yeah, this is a retrograde, this is the retrograde wire, and it is coming from the wall. You can see this is the aneurysm, so nowhere the wire is in the aneurysm. And when you further come close to the proximal RCA, I think this is a wire, so which is coming from subintimal position into the true lumen, which you can witness here. You can see this is coming into true lumen. So it's a kind of retrograde, both Plaque as well as flap shift, which will happen. So once you confirm this position, then you can move on to your next step of externalization. And we can see the picture. So this is where the aneurysm, this is where the wire is. This is a retrograde Gaia 3 wire, and this is aneurysm, and this is a sinoatrial branch. You can as well see here, this is a wire, and this is aneurysm. So nowhere wire is within the aneurysm. So that is very important. So once that is confirmed, we externalized wire. So for externalization, what we did, so we advanced microcatheter, beyond the total occlusion, and then de-escalated wire back to regular wire, and then it is directed into the antegrade AL. This was a bit difficult step and time taking step, and once the wire is into antegrade gyre, we can externalize much easily. Then we did IVUS after pre-dilatation. You can see here. So yeah, this is the IVUS, and which clearly shows, which clearly shows, you can see here, this is the aneurysm, and this is a flap, which is superimposing onto aneurysm. So, and subsequently we stunted this RCA. You can see here, after stunting, that aneurysm is completely excluded. So aneurysm filling is not there. And this is a final IVUS which clearly shows which clearly shows the aneurysm exclusion. You can see here. So this is where aneurysm is excluded. You can see here, and this is the stent as well as the both flap as well as plaque, which is occluding aneurysm, and you can also see the hyperechogenicity in the aneurysm, and good speckling in normal speckling in the coronary. So that clearly says aneurysm is excluded from the true lumen. So learning point from this case is injudicious use of high tip load CTO wires can lead to pseudoaneurysm when space is connected to aortic pressure, which can happen especially at proximal cap location. In cases like this, wiring strategy is largely impacted by the aneurysm location and its anatomy, and plaque or flap lift and shift can be done either retrograde or antegrade techniques depending on the anatomy of pseudoaneurysm, so which further can be studied by intravascular ultrasound to make sure that aneurysm will be excluded properly. Thank you. To watch more such videos, you can subscribe to our YouTube channel, or you can look at our website where these videos will be uploaded.